Yes, please. Okay.
Okay, great. So welcome everyone to our second lunchtime seminar, CFPR lunchtime seminar this semester. First, let me thank the staff for doing all the work to get this possible for us. So, and also Puck for arranging the speakers for us. So we have international renowned speakers to share with us their work, and we can learn a lot from them. This is a multidisciplinary disciplinary center, the CFPR. So we do have people from different disciplines: economists, demographers, sociology, psychologists, public health, and so on, who join us. And today we're very fortunate to have Professor Kayuet Liu from the Department of Sociology in UCLA in the United States to come to share with us about her research. Professor Liu got her PhD degree from the Sociology Department in Oxford University. And after that, I think she has been teaching in UCLA since then, right? And sorry?
I did a postdoc at Columbia University.
Postdoc at Columbia University too. Yeah, that's great. Actually, we were hoping that she will be joining NUS by now. Last year, unfortunately, that didn't happen. So we're very, very happy today that we have a chance to hear from her. She's done a lot of work, and her research lies in the intersection between social network analysis and social epidemiology. She's done a lot of work that I have no exposure whatsoever before. So, in the medical sociology field, and like autism epidemic, vaccine refusals, premature death among undocumented immigrants, and so on. So this is very exciting for me to hear what she has to say about today's topic on obstetric interventions, neonatal health, and child development, which I'm sure is quite related to our many of our work, including our work on early child development that has a health component as well. So Professor Liu, thank you so much, and the floor is yours now, please.
Thank you so much for having me, and I look so looking forward for your questions and comments. And if you have questions, anything that's unclear about the talk, I'm fine with interruptions, and just ask away. So let me share screen. So here, it looks all right?
Yes, perfect.
All right, so today I'm going to share with you my ongoing research on neonatal health and child development, particularly about like C-sections and inductions and their potential roles in affecting short as well as longer term child development. This is a joint project with my wonderful colleagues from multiple sites. So we are lucky to have received NIH funding for this project, and my colleagues at Columbia University, Rutgers University, and UCLA are a big part of this big project, and we are grateful for the support for all our population centers from all these different institutes. So okay, so well, let me set first. Well, you may know this already, like there has been a so-called epidemic of cesarean section around the world. That's what the journalists would be calling it, but in a sense it's true that in many locales around the countries around the world, there has been an increase in C-sections, particularly for as a delivery method. In the US, we have around 32%. And Singapore, I've been reading about it. The figures I got is around 40 to 45%. But of course, many of you are the expert of the statistics you have in the city. So like, let me know if you have more updated data on Singapore than 2017. So what this is showing is like in many locales and countries, C-section rate is much higher than what the World Health Organization recommend, which is about 10 to 15% of all births. So why do we care? Like there are more C-sections than the World Health Organization would recommend. So it's because of this trade-off. To be absolutely clear, C-section can be a life-saving intervention that would, when the birth is high risk, we need the C-section to prevent maternal morbidity and mortality, as well as infant mortality rates. But research has shown that a C-section rate that are higher than 10% do not give you extra health benefits to the mothers and the children. Instead, it can cause like unnecessary C-sections, can cause significant and sometimes permanent complication to both the mother and the child. We have quite good evidence on the shorter term complications on the mothers and the child, like they have to go back to the hospital within 1 year of the birth and so on. But the longer term effects is what our project is part of a project is concerned, like developmental outcomes such as autism and other developmental disabilities to the children. So one of the contributions of this project is to look into this kind of longer term effect to the kid that might be associated with C-section. The project, another innovation of our project is that we don't only look at C-section, but also induction, like medical or surgical induction of birth, which also parallel the rise of C-section. There has been almost a threefold increase in induction in the US among all births. So we look at long-term effects of C-sections and inductions in our data. And then you may be curious why we want to focus on autism in particular. My postdoc work, as I mentioned a little bit earlier, at Columbia University has been mostly on the rise of autism prevalence in the US. Like it has been quite puzzling among the research community, like how something like autism, which is supposed to be a genetically determined disorder, can be increasing so rapidly during like 4 or 5 decades. This graph, I'm not going to go into the details, but showing you from different national data sets have been all showing a rapid increase in autism cases. From this is the pink line is where our data come from, the California database on autism. You can see that in the early 90s, there's very few cases to close to 1% in the most recent data. And in other national data sets, it has been estimated 1 in like 57 children in the US has autism. So of course, correlations do not equate, it's not the same as causation, but we need to ask whether these two trends, the rise in C-sections and induction on one hand, and autism and other developmental disorders among children, could be related. Could there be could the increase in C-sections and inductions be causing or contributing to the rise in autism? Research have shown that children who were born after C-sections indeed are more likely to have health issue, including autism. We know that already, and it makes sense in the sense that like they are also more likely to other related conditions like sensory perception and sensory integration problems. Those symptoms are very correlated with autism. We already know that. So it seems that there's something going on between like the delivery method and autism. And there are biological pathways that should explain why they should be causally related. For example, if you have a C-section, you're likely, the kid is likely to have reduced the gestational age, so they're more likely to be born preterm, like not having a full gestational age. And there are other biological mechanisms that has been proposed, such as like without going through the birth canal, they're not exposed to the healthy microbiome of that could have been happened with a spontaneous vaginal delivery. However, like we have to, like of course, like there could be plausible pathways, but in order to establish that that indeed C-sections or inductions have really something to do with autism, we have to control for medical risk. It's possible that some underlying medical risk of the birth, like either the mother or the pregnancy, could lead to the decision to have a C-section, as well as has an independent contribution to the autism symptoms later for the children. So, but existing study that, although they have found that reported the correlation between C-sections, inductions, and autism, they have not done a fairly good job in accounting for medical risk. So that's where we come from. Like, we are specifically looking into elective deliveries. And by elective deliveries, we mean that the intervention, like the C-section or the induction, is not medically necessary. There's nothing on the clinical record of the mothers or the birth that indicate that there's some underlying medical risk that warrant the intervention. So by focusing only on elective deliveries and where they are still associated with autism, we're trying to rule out just potentially important confounding factors. Okay. So this is the background of our project. And specifically, the rest of the talk, I'm going to talk about the main research we have on elective deliveries, like medically not necessary deliveries in autism. And after I give you the short version of the results, and I will tell you a little bit about our ongoing work in understanding why there has been an increase in C-section and inductions. All right. So let me tell you a little bit about our data structure. So although autism has been increasing, it's still a relatively rare condition. So to study autism systematically is very demanding on the data. So this is a population-based study, like a registry-based study. We use administrative data of all births in New Jersey and California. So we take the birth records, about 2 million births in New Jersey and over 10 million in California. We take that and then match that with probabilistic matching to all the hospital records in New Jersey and California. the point is to get the medical risk of the birth, so that we would know, like, in fact, this birth is unlikely to be a high risk birth, that a C-section is actually appropriate. So from the hospital records from both states, we would know things like with the gestational age of the birth. We know the medical diagnosis on file for the mothers and the pregnancy. So again, this is all register based. It's not like a detailed clinical record review that you might be able to do at the hospital, but the advantage of our astrology is that we have a lot of observations. So that's how we defined, how we identified our elective deliveries. And then because we have the addresses at birth, we can know a lot more about this mothers and children by embedding our data in neighborhoods with socio-demographic characteristics from the census, and we would know the distance to each other and so on and so forth. So that increased the number of potential contributing factors that we can explore. Well, lastly, I need information on autism. Only in California, California is the only state in the US that has a centralized service provision for people with autism. So this is a state that the central agency would coordinate the service for any person with autism, to give them a diagnosis, to provide them with service and extraction. The state agency cover more than 80% of everybody with autism in California. So that's my outcome variable. So this is how our data look like. The bulk of this work is just getting these data sets, all this data, merge them, clean them, and stuff. So that's the 2 years of this project is spent on getting this ready. So if any of you as a graduate students are interested in how that works, email me. I'm happy to share like all the nitty-gritty. So here we go. And we don't have that much time today, so I'll just jump right into the result. But let me first define my main independent variable, which is delivery methods. We have induced vaginal deliveries. We have C-sections that did not follow any attempt to induce. And there are C-sections that follow attempt to induce but failed, so that they would end up being a C-section. And the reference category is spontaneous vaginal births that have no induction and C-section. So that's our main result. This looks complicated in a little bit because we fit many different models to try to rule out confounding factors and so on. But the main model is highlighted here. This is a model fit to our low risk birth. Again, by low risk, we mean that there's nothing on the mother's hospital records that indicates any medical diagnosis that would warrant a C-section or an induction. And the list of diagnoses, I should have mentioned, the list of diagnoses we use is based on an algorithm proposed by a national agency, the official list of recommended by the US government, basically. So our low risk births consists of mothers who have none of the conditions that should suggest an induction and then a C-section, and then if they're all first birth, like this is a first kid they have, and then they are all singletons, like no twins, no multiple births. So among all this low-risk births, with the outcome variable as an autism diagnosis, we find that the risk of autism is about 20 to 30% higher among elective C-section births compared to our reference category of spontaneous vaginal births. We also find that induction also carry a small increasing risk in about 7%. So this is an odds ratio. So this is a logistic regression model with the outcome being autism diagnosis. So that's how we get our results. Like, other than limiting our analysis to low-risk births, we also adjust for some known factors for autism, such as mother's age, mother's education, ethnicity, and so on. So, and we do many other stuff, like rule out any, like excluding all the births that have the mother has even ever get an encounter with the hospital system the year prior to the birth, and there's nothing happened there's nothing we know that would give us a red flag that this might indeed would have been a high-risk birth. So we do all this additional analysis, but I don't know, like it's the odds ratio just do not budge. They just look like that all the time, no matter how many control variables I throw into it, into the model. Like I control for mother's zip code, I control for the hospital itself as a fixed effect, and so on. So, but the results are very similar. Okay, so yes, I just mentioned I controlled for other things, and it just doesn't really make a dent to the odds ratios, and which give me, I'm pretty skeptical about any research, but I just can't explain it away, so I have to accept that these are robust associations. And we have also in this paper tried to identify pathways that might have explained our correlation between delivery methods and autism. To our surprise, that the associations are not explained by a shorter gestational age, like even among pregnancy that has like really full term, we still see this association between delivery methods and autism. Like children born of normal birth rate, we still see the same association. We try to look for maybe the association is explained by neonatal conditions such as like respiratory conditions, because we know that children born after C-sections, because without going through the birth canal, they're more likely to have breathing problem, basically. So, but this doesn't explain our findings. So the bottom line is we don't know. Given what we can test, we cannot fully explain why there is an association between autism and delivery methods, but we have some like further research need to look into potential mechanisms that we cannot figure out from the hospital records itself. So that's the mechanism. Does it matter? Like this is a very crude way to gauge whether this is an important factor. This measure in epidemiology that's called population attributable fractions, give you a vague, like a rough sense on how many potential cases you can reduce if you were able to remove the risk factor. So according to this measure, like our model, we are thinking that up to 10% of autism cases among the low-risk births could be prevented by avoiding medically unnecessary interventions. Is 10% a lot? Like it depends on whom you ask, but according to the literature, is 10% is bigger than advanced maternal age, which has an equivalent effect of about 2-3%, like having kids at a later age for the mother. And also known associations between environmental toxins and autism is less than 1% according to this measure. So this is quite important according to our estimation. And the key point is this is a modifiable risk. There are here already a long history of research saying that we should avoid medically unnecessary C-sections and inductions if we could. So our research, I think, joined this choir of calls of saying like if this is not medically necessary, we should consider autism also as a potential adverse outcome of a necessary intervention. I will be quickly talk to you about, because that's the public health part of this project for me, but I'm a sociologist in a way. Like I joined this project partly because I'm interested in the public health importance of it, but as well as a puzzle for me, what is driving such increases in C-sections and induction? Like it's the typical sociological puzzle for me. Like how can something that is supposed to be a medical decision change within such a short time and vary so much across countries, right? So typically we'll think about like supply side factors, like because in the US, like the doctors are afraid of being sued, so they would do a C-section because they would be seen as doing something instead of just letting the pregnancy go the way it is going. So, but then you would hear, if you ask the doctors, they would say that no, there is the family. The family are requesting them. It has nothing to do with us. So that's the survey results. On the demand side, as a sociologist, we would be thinking like maybe there are reasons like because women nowadays have participate more in the labor market. They want to have more control about over their reproductive life as well. They have concerns about the quality of life after childbirth, and as a medical sociologist, we would be thinking about how the procedures are perceived, or like which one is safer. Like now we are in the COVID epidemic, we all know like such perception about whether say a vaccine is safe make a huge difference to people's behavior. But it still bugs me, like why could there be such a big across-country difference? It's like it is not just a rich country issue, the rise in C-section. Like this is a graph of C-section rates across a wide range of countries. And then you can see like it doesn't really have a strong socioeconomic kind of pattern, right? Like you have very rich countries as well as not so rich country in the mix. Like, so if the story is about what I have been talking about, like the demand side factor and the supply side factor, we would have expected it would be just the rich countries problem, but that's not the case. So, I'm currently looking at the social diffusion process of norms and practices around C-section that might help us explain the heterogeneity. Just very quickly, I'm looking for spatial diffusion patterns among parents using the New Jersey data. I want to leave more time for Q&A, but like if you're interested, we can come back to this part of the project later. But what I'm doing is I'm using some spatial methods to scan for clusters of C-sections and inductions in both New Jersey and in California. So why do these local clusters matter? Because like if it is something very universal, like a general increase in maternal age, for example, or the change in insurance laws, something like that, or the provision, the level of medical resources that are available to everybody. We shouldn't be expecting, we won't be expecting local clusters of C-sections and inductions, right? But to the contrary, we see clear patterns of spatial clusters this is California, as well in New Jersey. There are clusters of such obstetric interventions. It could be due to multiple different reasons. It may be just certain kind of parents self-select into those neighborhoods. It may be something about the hospitals there that in those neighborhoods that have a higher C-section rate, for example. But what I'm interested most in is that whether we can, whether it's the interactions between parents that lead to such local clusters. So this is, this is many models in just one slide, but the bottom line of the take-home point of this analysis is that even if we control for individual characteristics, if we control for hospital random effects in a multi-level model, if we control for physician effects, again with a multi-level model, you would still see living close to someone who just had a C-section compared to living to someone who are farther away and had a C-section, that you will still see and increase the odds of having a C-section yourself. So there's a proximity effect of living close to someone who had a C-section. And it cannot be explained by what I was seeing, like self-selection into neighborhoods on observed characteristic. It cannot be explained by hospital or physician effects, as we could control for them statistically. So this is what I'm working on this week. So I welcome your comment of how I can improve this analysis. But to sum it up, I'm looking into the social interaction effects among parents, and which may have contributed to the uneven spread of elective deliveries. Lastly, this is the last busy result slide I have, I promise. So I'm also looking at the diffusion potential diffusion of the practice among physicians. So New Jersey is unique in the sense that we know the names of the attending physicians, so we can trace their C-section rates across the career. So I'm looking at like the correlations between colleagues' elective delivery rates, and like if a high C-section rate, doctor moved to another hospital, what is going to happen to that new hospital, for example. So that's what the second line of ongoing research I'm doing for this project. And why should we be looking at the physicians is that like it actually matters. Like physicians have a lot of leeway in a sense, like they can justify C-sections and say that this is medically necessary, and then let's go ahead with a C-section, for example. And this graph is showing you like this. I don't know, maybe some of you work with ICD codes. These are ICD codes that physicians use to justify C-sections, and they have to mark it on the hospital records so that they can be like they will be properly documented, and there are also implications for insurance. But you can see this huge jumps in certain ICD codes that are on the mother's hospital records. That doesn't make any sense at all, actually. Like that's only like a 7 times increase in post-term pregnancy over a short period of time. So this interactions between institutions and medical risk that makes the story much more complicated, and we need work to do work to unpack it, like to really understand whether there is a real increase in biological risk, or is this just a social phenomenon that us sociologists can contribute to understand our understanding. Okay, so that's all I have for results. To wrap it up, our result seems to support we can reduce at least some of the autism cases by avoiding medically unnecessary interventions, and it's seldom we have modifiable risk factors, and I think it's clear that we should act on it. But the later part of my talk is about like we can't just tell doctors not to do C-sections. Basically, we have to understand the underlying social mechanisms that might be driving the increases, so that we can have effective policy that would address the reason why doctors are carrying out more C-sections, or why people are having more C-sections and inductions. Thank you.
Thank you, Ka. Maybe you can stop sharing your screen now. And let me invite everyone to join in our discussion. We have some time for question and answer. If possible, may I invite you to turn on your video so we can see you and feel closer to each other? I haven't seen many of you for a long time, so I like to see you too. Our speaker, I'm sure, will appreciate that too. Good. More people? Okay, first let me encourage all the students to ask questions. Don't feel intimidated. This is a learning process for all of us, and I'm sure you have lots of questions, whether it's substantively or methodologically or anything, I'm sure our Professor Liu would be very happy to explain what you want to know better. So yeah, feel free to ask questions. All right, we have a question from Sean Wang. Since we have a small group today, actually, Sean, would you like to ask the question yourself, please? Unmute yourself and ask the question.
Okay, hi.
Hi.
Hi, I just want to know whether because I think you took data from probably the 90s to maybe the 2010s, and so I was wondering whether because in this the diagnosis of autism using the DSM-5 SG and the DSM-3 then has actually changed. So there's actually also a greater understanding of autism among parents and among the general population. So I was wondering that this rate actually has been shown to increase because there's greater understanding, and parents has been sending their children for more diagnosis and more sort of early interventions. And I also wondered whether that these babies born to C-section perhaps has more behavioral deficits as shown maybe in age 2 or age 3, that also this form of diagnosis to seek sort of a diagnosis, to seek an autism diagnosis as compared to maybe those who don't have a C-section.
Right. So great. Thanks for the questions. Yes. Yes, it's a decade of changing criteria for autism. My previous job at Columbia University studied the questions exactly that you asked, like whether there's a diagnosis, changing diagnostic criteria effects in particularly the DSM. Roughly speaking, what we have identified it has contributed to about a quarter of the increases in autism in a decade, but which leaves the bulk of the increase still yet to be explained. So that's my colleague Marisa King's work, and you please look it up if you are interested. And my main job at Columbia was to understand what you described as increased awareness and knowledge among parents. And indeed, yes, we have found that it's a crucial factor, and it has quite a substantial impact on increasing the autism prevalence in a sense. So like I'm agnostic to the question whether they are real increase or not real increase. Like we know that this raising awareness has contributed to the rising prevalence. The questions about symptoms, if I have a supplementary slide, but I don't think I need it. No, it's actually the association between autism and delivery methods actually observed it regardless of symptom severity. So severe cases, mild cases, there is still an association. I looked into it because I thought that if it's just about like mothers who are, I don't know, pretty anxious about the births, maybe like so that they had a C-section or had more interventions, maybe they are more likely to seek an autism diagnosis, even though the symptoms of the children are mild. But we don't see it. We see this association between delivery methods and autism across all symptom severity, which leads me to believe that there's something actually biological going on rather than the tiger mom is trying to do too much. So that's my take from the data.
Okay, thank you. Book, you're next.
Oh, sure. So I would like, I had very little knowledge about this literature. So this has this association been established somewhere else outside the U.S. Between C-section and induction and
Yes.
autism?
Yes, so top of my head, I think Scandinavia, Japan, like it's a wide range of countries, not only the US. Yes.
Okay.
Okay, Shijao, you have 2 questions.
Yes, thank you for this talk. This is very interesting. And my first question is related to Sean's first question about the awareness. So I'm also wondering whether you see any cohort effect or time effect as your data is from a wide range from late 19th to 2010. So maybe you can check whether you see stronger effect or something like that. And another thing is I have very little knowledge about autism, but I suspect there should be some genetic cause about this autism. And so in your data set, you only use the first birth, so there's no siblings or any relatives. So I think maybe sibling analysis or cousin analysis may help to see whether in the same family, when child have different delivery modes, whether they lead to different health outcome. Yeah.
Right.
Thank
So
you.
great questions. Yes. For the cohort effect, yes, there's a very strong cohort effect in data. Because the trends have been increasing for both C-sections as well as autism, and as Sean was mentioning, that there's a general. I don't think that's all of those increases has to do with biology. There's some strong social processes going on behind those 2 trends. So we have been controlling for birth cohorts, and we have been doing cohort fitting our models to each birth cohort, but we are consistently observing this association across time. So and the effect is bump up and bumps around, but it's quite strong in the later cohorts compared to the earlier cohorts. And be my guess, guessing why it would be the case. And then the second question, you were saying that, sorry, can you quickly remind me?
I mean, there may be some genetic cause of the autism.
Okay, thank you. Yes, so yes, that's my previous work at Columbia. Yes, that's we had a paper in demography about the genetic contributions of autism using a twin and sibling data setup. So what we find is overrated. The heritability of autism has been vastly overestimated. It was supposed to be 90%, but according to our estimate, it's about 40% actually, which is on par on a lot of behaviors actually. So it's not super genetic, but we have been led by earlier findings that it is the most strongly genetically determined psychiatric disorders among all disorders. We have been stuck in that mindset for a long time. I even if I talk to autism researchers, they still think that it's very genetic. But later study, there are 2 big study, one in very high profile studies that replicate our finding and put about 40% as the heritability of autism. But great question to use a sibling design for the delivery method. The reason why we didn't do it, because we really want to stick to low risk births. And by definition, second births or third birth, do not fit the government's definition of low risk. So it's hard for us to do a clean picture of like controlling for medical risk if we take a sibling designs. If what you are concerned with is not elective delivery, you just care about delivery method. There are papers out there using a sibling design, like a family fixed effect design. And some people find an effect, some people didn't find an effect. But it's hard to compare our research with their research because exactly, we're only looking at low risk births. But they're not. So it's not really directly comparable.
Sorry, you said second birth and third birth is not considered by the government as low risk birth? Did I hear that correctly?
Yes, the definition we use, the government recommendation for C-sections is, as maybe I overtly simplified, because there's this great dependency between C-sections of siblings. So if your first kid was born in C-section, it's 95% sure that your second kid would also be born with C-section. So that's this dependency across within the family. So right. the government algorithm we are relying on do not consider second and third birth, not because they are high risk, but because of this dependency.
Okay, I get it. I was actually also going to be asking you about the sibling analysis, but I'm glad you mentioned it. But if you take the first kid as natural, if the first child is natural birth, and the second is C-section, then that's possible, right? I mean, there's no contingency dependence.
Yes, it's possible. I have done it, and I haven't included the results in the paper, but I remember I still see the association. Yeah.
Okay, great. Simonia, you're next. Would you like to ask a question, please?
Yeah, I wasn't sure if I had missed this in the talk, but I just wanted to ask, has the data been adjusted for the possibility that, there's a correlation that increasing maternal age leads to increasing prevalence of autism, as well as the paternal age as well. So I was just wondering if that has been adjusted.
Yes, we have adjusted for maternal age as well as in alternative specification paternal age. It doesn't change your odd ratios. And we also have stratified, and it looks the same.
Also, this wasn't what I had typed, but I also wanted to ask, because you had mentioned something about the ICD codes. I also wanted to ask if you looked into the insurance reimbursement rates for those codes to see if they're like actually higher. So that maybe also can be explained why they're being used, because hospitals can use those codes to bill for higher reimbursements. And from what I understand, my limited knowledge of C-sections are that, if you can actually bill insurance to generate like more income from that, like you would use those specific codes to maximize your chances of getting the greatest amount of reimbursements. And I think the reimbursement rates also vary from insurance carriers. So if you were to bill like Medicare, Medi-Cal, or other private insurances, you might also get different reimbursement rates as well. I don't know if you wanted to look into that.
Yeah, that's a great question. We do have the information on insurance. We have the insurance code, how much they billed and stuff. It's just such a complicated thing to understand, to do such analysis in the US system. Like it could be different codes, but it's actually the same insurance plan or vice versa. So economists have done the analysis that you described, and they have found clear evidence that that C-sections can be billed like 10 times more that compared to a spontaneous vaginal delivery. And whether the doctors actually intentionally doing it for the money, like we will have to ask them. I wish I can do a similar analysis in a system, in a healthcare system that is less private oriented. I don't really know the Singapore healthcare system that well. Like, would it be something, if we can take away the financial incentive, if we do this? So I'm from Hong Kong. In Hong Kong, is a universal healthcare system. So we would have a cleaner picture of what's going on. Like, is it the physicians or is it the parents? So I would love to do some comparative study on this.
You might also want to possibly look into, because sometimes the doctors in major hospitals, they themselves don't do the billing. It's the hospital administrators that do the actual billing process. So it could actually possibly be driven by that. And one way to possibly look at that is to look at which departments generate the most financial, with the shortest amount of turnover time. Because the longer a bed is being occupied, the less profit or amount that they can bill insurance. So you might also want to look into like which department is the greatest amount of like cash that like is contributed towards the hospital. Because I'm assuming you're looking at births in major hospitals and metropolises.
Yeah, that's a great suggestion. Like, one of our goals in the next few months is to unpack the physicians and the hospital effects, and that's a great suggestion to look at the building department itself. Yeah.
Okay, great.
Sorry, never mind. It's okay.
We have just a few minutes. Christy, would you like to please ask your question? Unmute yourself, please.
Yes.
Hello. Yeah, go ahead.
Hello. Thanks for your presentations. I find that I'm in psychology, so also doing a decision, the medical decision making research in STM as well. So I find that your finding is been like it's not to you in this field, in neurology, psychology as well. So the finding is already in the research in the West and in Japan. I bet my base in Japan. So US, we also look through this. So I would like to know, could you, I think the meaning of your research is like you want to have some actions in based on this finding and this outcome. You would like to do some contributions to raise up the awareness in the public for the decision making. Right. So may I know what is your plan in this? Your purpose, could you clearly elaborate for your research purpose? And also, you never touch about the medical treatments. I find in this point, they also raise up a lot of treatments and how to cope with it. Because everything that, whatever things that, like for example, we have COVID-19 vaccinations, and we also need to cope with the side effects. So for CD, the correlations and the ASD, there is already many people already many findings come out in the research field in neurology. Is have the same outcome. So the problem is how to extend this to contribute to our society and to our world. So this is what I would like to know. Do you have a plan to put on the situations of the treatment, medical, how the current, how is the status, and also you have other plans in to do to use this finding to step on the next step in from the point of view from sociologists. Just how you mentioned, you are the sociology. Your main focus is in sociology. Okay, thank you.
Right. So yeah, so you're definitely right that we see some parallels on other outcomes. Like in psychiatric and other neurological disorders. But I think our main contribution is really seriously control for potential confounding factors for as medical risk as confounding factors. If this is all merely correlation, there's no policy recommendations that we can give because it's just like a whole bunch of unrelated things that happen at the same time. So my agenda is to get the science right, first and foremost. And then for policy, my collaborator is more an expert on this. But in more generally speaking, we have seen real behavioral change in delivery methods. The change in medical guidelines in the past, in 2018, have really made the level of C-section plateaued. So this is an area like really well thought out research can make an impact to actual health outcomes. That's what got me excited in this project. So I don't really have concrete terms. I don't have the phone numbers of the politicians, but we will try to do that.
Okay, this is really amazing work. I really appreciate what you have put in. Some may not appreciate how much work you have put into this, but I want to point out that every single slide that Professor Liu has shown us has involved tons and tons of effort. She had mentioned that she spent 2 years just getting some of the data comparable and straight, and then after that a lot of work. So this is amazing and really excellent work. I think it's very interesting that you're finding this network phenomenon that clusters, neighborhood clusters, I guess, and it's fascinating to see there are neighborhood clusters, but to understand that, I'm sure it needs a lot more work. Whether it's these clusters, Malibus, or these high-income clusters, or what kind of cluster, I'd like to know a little bit more about that. But all of this make me think that probably more attention is needed for the more institutional and policy factors at the maybe not neighborhood, district or state effect, or whatever, that are affecting both the demand, maybe more the supply side than demand side. I think the demand side isn't something that fluctuate up and down so much, but maybe policy, if there are some changes over time in the policy, in California, for example, or in other areas that you're looking at, that you could try to look at to maybe help understanding the sociological side of it. I think that would be really, really valuable. So what kind of clusters are these?
They're not, thank you for the kind words. To answer all your questions, that's my agenda for the next few months. But the clusters are not only in wealthy neighborhoods. It's kind of, we're trying to unpack this, but we have, the maps I've shown you have controlled for social versions of it, have control for like neighborhood income and property values, but you will still see the clusters. So it's not just a simple story about wealthy people who can afford a C-section living in Malibu. And so the interesting thing is we have data from 2 states, so we can test with the data from 2 different states. We can test for some more general mechanisms that is not like particular to California or New Jersey. Yeah.
Yeah, you've got a lot of work cut out for you for this, but very important work and excellent effort, I would say. We're now almost 7 minutes over time. So I'm sure if you have more questions, Professor Liu would also entertain more discussion with you as well. You can contact either her or us to pass your message. Thank you very much for Professor Liu's excellent presentation. It's a really fascinating work and important. We've learned, I've learned a lot. I've learned a lot. I have observed the increase in C-sections, but to have a more systematic understanding about these phenomena and how that might potentially lead to some of the developmental outcomes that are also very important. It's good learning for me. So I hope for most of you, you have also learned a lot. There's a lot of methodological issues that I was going to ask, but there's no time for that. I'm sure we have, we hope to have a future opportunity to learn from you more about about your work. So thank you very much. And thank you everyone for your participation and excellent questions and discussion. We hope to see you on our next CFPR lunchtime seminar. Until then, stay safe, take care everybody, okay?
Thank you. Thank you so much. Please
Thank
email me
you.
if you have
Thank you,
questions.
Ka.
Thank you, Bye-bye.
Bye.